I would have forgot. Uh, anyway, welcome to Timpanogos EMS in service. We'd like to welcome Orem Fire here and thank them for hosting this event always and having a great place to be able to hold it, and for the platoon that's here, and hopefully we get more guys, right? I don't. You probably have some that are still out. Yeah. Anyway, you guys, thanks for everything that you do to be able to make this happen. We'd like to thank Dr. Cameron Meyers for being our presenter this morning. He works at Mountain View as an ED physician down in Payson, and he's been there for how long?
6 months.
6 months. He's awesome. He's awesome. I says, you have got to.
They're already talking about getting rid of me, so it's not bad.
Yeah, you have got to come up here and lecture for these guys, because Orm's awesome too. So anyway, so I wanted to make sure that you got up here. But anyway, so Cameron, he's been an ER doctor for about three years approximately, right? You're from Salt Lake.
From Salt Lake.
Yeah, it's from Salt Lake, and he came from Ohio, from a level 1 trauma center up there, and he's done his residency and worked up in that area. And so he has seen a lot of stuff that we see occasionally, right? when you're in a big trauma center, you see a lot of stuff all the time. So anyway, I've seen him present before. He's presented this particular topic for us before, and it's a great topic, and it's because you guys bring in STEMI to Temp, and we go to the cath lab a lot. This is a really great one because it really talks about, STEMIs and STEMI posers, and it's really nice to be able to know the difference and to be able to tell, because it just kind of makes a difference on what we do, especially in the ER and at the hospital. So anyway, with that, just a little bit of housekeeping items. If you are online, please in the chat, if you can put your name and your department in the chat. If you want a certificate of attendance, please put your email. I will send that to you, or I'll send it to your training officer so that you will have that for your records. And then any type of questions, you can put yourself off mute. We do have a speaker here, and you can ask questions. So go ahead and feel like that you can do that. Other than that, make sure that you're muted during the presentation until you've got a question. And then with that, we'd like to turn the time over to Dr. Meyers. And then can you guys see online? Can you guys see the PowerPoint that we are sharing?
Yes.
Awesome. Okay. And then you can hear okay?
Yes.
Awesome. Okay.
Hey guys, my name's Cameron. Like Chris said, I just moved here from Ohio, from Salt Lake originally. Came back home, regretting it already, but that's okay. I'm just kidding. So EKGs kind of are not really the most exciting topic, but I'll do what I can to kind of make it a little more interesting. I want it to be more interactive, so I'm gonna ask you guys a lot of questions. I just so you know, I don't know. I'd give you $5 if anybody knew who this is. A picture of this. I come from a family of like uber nerds, which I'm not very proud of, but in an attempt to make this a little more interesting, I don't know. I'm changing things.
Two things at the same time.
So this is Jedi Prime. So from Star, my family's just uber nerds when it comes to Star Wars. So this is the first Jedi ever, supposedly named Jedi Prime. So what we're gonna do is, I feel like this topic should probably be called like becoming a Jedi Master of EKGs, as opposed to just STEMI and STEMI equivalents. So we're gonna kind of work our way up from like the levels. So I'm hoping everybody gets something out of this. We're gonna start off with very basic stuff, and then we're gonna progress to stuff, and hopefully there's gonna be stuff in here that none of you have ever heard of either, or seen before. If you have, great. If not, I just want you at least to be familiar with it, kind of heard of it before, and you guys can always ask the ER docs about it if you have any questions about it. But I just want to just kind of go through it. So we're going to work our way from the top. So we're going to start out baby level, right? We found out that you have the force with you, but you've had zero training whatsoever. How do I get this out of the way? Just want to move that.
Do the
That's okay.
routine stuff, two of them.
It didn't work. That's fine. Awesome. So we're talking about baby stuff here, right? So this is like the most basic EKG stuff. No, it's not.
Applesauce, yes.
Hold on here.
Features,
There we
yeah.
go. Perfect. All right. So this is an EKG, obviously, right? So this is like a rhythm strip, right? So there are different parts of the EKG, right? So when we're looking at the,
Trying to
I'm
do a
getting in the way.
STEMI.
So when we look at the different waves
Same
on the
time.
EKG, right, they all represent the electricity going through the heart. It's not actually the contraction of the heart, right?
Two things at
So
the
the
same
P
time.
wave represents the,
No,
the electricity causing the
I've actually
contraction of the
already
atria.
seen this training
Gene.
once.
Gene, you're off.
But-
You're on. Would you put yourself on mute?
Right. So the P wave is the electricity of the contraction of the atria. The QRS is the electricity that causes the contraction of the ventricles going through the ventricles. And the T wave's kind of the repolarization, right? So told you, pretty basic stuff. So I love looking at these pictures to help us understand what the EKG is actually doing, right? So I like that triangle. Kind of helps us give us an idea of what part of the heart we're looking at with each lead. So across the top is lead 1, right? And I always think about the arrow where it's pointing. So it's pointing at the left side of the heart, right? And then you can see AVL is also pointing at the left side of the heart, right? Kind of more the top part of the heart. 2, 3, AVF is all pointing to the bottom part of the heart. So that's the part that you're actually looking at. That's the certain direction, right? Of where you're looking to see if there's a problem there. And then you have the precordial leads kind of wrapped around, right? So I love this diagram of the 12 lead EKG because it actually shows you where they are. I don't know why somebody couldn't group them in an organization that makes sense, right? So the left side is the limb leads, the right side are the precordial leads, but so you can see where the lateral ones are, where the inferior ones, the septal, right? So the V1, V2, we call the septal leads, V3, V4 are more the anterior leads, and V5, V6 are the lateral leads, right? So I don't know. For me, I had to sit there and look at these 3 pictures to really feel like I understood the EKG. All right, so now you're like an apprentice now, right? So now you got that basic stuff. All right, now we're stepping up our game, right? So now you're actually in training, right? So our main topic today, right, we're going to talk about STEMIs, right? So even more important than STEMIs, when I'm looking at an EKG, when you guys send an EKG to the hospital or I'm looking at one, what I'm actually looking for is not just a STEMI, but I'm also looking for signs of ischemia, which sometimes are just as important as having just a STEMI, because it'll still show us stuff, and a lot of times we'll still send them straight to the cath lab if we see problems, right? So what are the signs that we see of acute ischemia on an EKG? Inverted T waves, perfect. Anybody else? That's all we got, inverted T waves. What about a STEMI? ST elevation, okay. That's all we got? Volunteer firefighters got way more than you guys did. Sorry, what? Yep. Okay. What changes though? Sorry. Reciprocal changes. Okay. Here are the signs of ischemia that we're looking for. Okay. Hyperacute T waves. We'll go over all these too, right? A hyperacute T wave we'll go over is a sign of ischemia. T wave inversions, which you mentioned, ST depressions, ST elevations, and even Q waves, right? So Q waves we usually think is something you see after somebody has a STEMI. You'll see that long term, but in the right setting, a Q wave can be a sign of ischemia too. So, all right. So first we're going to talk about hyperacute T waves, right? See my little Pac-Man little guys there? What a hyperacute T wave is a symmetric pointed T wave. A lot of times we think of like peak T waves or whatever, high T waves, we think of like hyperkalemia, right? But you can actually get it when you have signs of ischemia, you actually can get these peak T waves that are symmetrical, and they're always taller than they are wide. So I don't know why, but for some reason, trying to remember all this stuff, I thought about Pac-Man, right? So Pac-Man, when you look at this T wave that he's lined up against, he could eat it going up, right? Does that make sense? but he can't eat it going to the side, right? It won't fit in his mouth, right? Oh, it's stupid, but it helps me remember that hyperacute T wave, it's taller, more tall than it is wide. Okay.
Yeah.
This can definitely be a sign of ischemia. Okay. Other one, T wave, inverted T waves, like you said, right? So we have inverted T waves. They're normally supposed to be up, except for leads 1 and AVR, right? But anytime you see inverted T waves, especially like you said earlier, new changes, there could be changes to an EKG, right? So if they're new T waves, they're definitely concerning for signs of ischemia. Okay. Oops, wrong way. ST depression. So you can see on these kind of anterior lateral leads there, you can see ST depressions. Okay. So they're the baseline. When you look at the baseline in an EKG, you actually, your baseline is between the T wave and the P wave, right? So that should be your baseline. You can see that QRS is lower, right? ST elevation, obviously, right? That's what we're all familiar with, ST elevation. And then these are Q waves. Well, at least look at lead V2 right here, okay? A Q wave is when you're going from the P wave to the QRS, and see how there's no upstroke right here and then going down? So when it just goes flat and then drops down, that's what we call a Q wave. We usually see that after, like if somebody has a heart attack, that's like the last change we usually see, and sometimes that'll just be permanent. That's why a lot of EKGs you'll see a possible septal infarct unknown like time frame. You remember you've seen that on the EKG? That's because you see that because they have a Q wave, right? But in the right setting, they didn't have that before. It's a new Q wave. They're having like crushing substernal chest pain.
Bandwidth.
Obviously, that would be
Issues.
concerning, right? All right, so now we're going to talk about the killer, right? What's going to kill you when it comes to an EKG, right? What are we looking for? What's our goal thing, right? A STEMI, right? So what makes up the two things I want you to get out of this are those, most of all, more than anything, is this
I just switched it to
what
my phones.
qualifies as a STEMI, and the other thing is what reciprocal changes are. That was my goal. If you guys get that out of this lecture, that's what I want you to know. So how do we diagnose a STEMI on an EKG, besides the computer telling us so? Which isn't right all the time. Anybody? Huh? Perfect. ST elevation, you need 2 or more. What word do we use to kind of contiguous, right? What does contiguous mean? Exactly, right? So they're next to each other, like physiologically next to each other, right? Because the stupid EKG of the lateral leads all over the place, right? So, but leads next to each other, right? Okay. ST elevation, 2 or more contiguous leads. What else? How much elevation? So it's good. So it's 1 box, right? So at least 1 box or 1 millimeter elevation, except for leads V2 and V3. Okay, but we'll get over that. So like in leads V2 and V3, it's actually normal to have a little bit of elevation, right? So essentially if it's 2 millimeters, that would be concerning, right? And one more thing, someone said it earlier, reciprocal changes. Exactly, perfect, right? So ST elevation, right, of 1 millimeter or more in 2 or more contiguous leads with reciprocal changes, right? Okay. The V2, V3 thing, it's a little bit different. So if you're actually a female, you need to have 1.5 boxes to be considered a STEMI, to be elevated. In a male under 40, it needs to be 2.5 millimeters. If it's someone that's older than 40, that's a male, it's 2 millimeters, whatever. If you just remember 2 millimeters, you're gonna be fine, right? Okay, so how do we look for reciprocal changes? I didn't know I'm gonna just drill you today. She told me it's Chris's fault. She wanted me to just drill you guys. She's like, these guys know everything. They should know every answer to every question you have. And if not, they're getting fired. What do you mean by all your other leads? The camera angles. I like that. Yeah, so the opposite side of the heart, right? Yeah, exactly, right? It's hard though, right? Because how do you know what side's the opposite side of the heart? The limb leads don't have exact perfect mirror images of each other, right? I'm the kind of person, I hate mnemonics. I think mnemonics are stupid, but I'm going to give you a mnemonic because I don't know why, but it helped me out. And it always helped me know exactly where to look for reciprocal changes, right? So the mnemonic is PALS, right? So what I think of, so we already saw like the different segments of the heart, like the septal, the anterior, the lateral, whatever, right? So when I always think about this, where to look for reciprocal changes, if you have elevations in the posterior leads, you're going to find reciprocal changes in the anterior leads. If you have elevations in the anterior leads, you're usually going to find them in the inferior leads. If you have elevation inferior leads, look to the lateral leads. If you have elevation lateral leads, look to the septal leads. If you have elevation in the septal leads, look to the posterior leads, right? Super helpful because sometimes I have to sit there and look at the EKG. If I don't remember this mnemonic, I'm like, all right, wait, where should I expect to see these? And I look all over the place. But just if you want to look at it really quick, I mean, this isn't exactly perfect, but like 90% of the time, these are where you're going to see the reciprocal changes, right? So you look to that, super, super helpful. It is not a STEMI unless you have those things we talked about and these reciprocal changes, okay? Here's an example, right? Do we see elevated leads? Yes, right? You can see them here, lateral leads, right? So 1, AVL, and then you can see V6 is a little high, V5 is a little high. Using our mnemonic, so if we have lateral leads, right, where should we look for the reciprocal changes? Septal changes, like, so look, septal, V1 depressed, V2 depressed, right? And even kind of spills out to the anterior leads a little bit, right? So definitely, right? So that is obviously a STEMI, right? So super, super helpful to think about that mnemonic, okay? So that's how we diagnose a STEMI. We're going to talk about a bunch of mimics. Always go back to those criteria. If you don't have those criteria, it's not a STEMI. That doesn't mean it's not concerning, because you can still have concerning EKGs that aren't technically a STEMI, which we're going to go over, but not a STEMI, right? So now you're like a young Jedi. You've done your training, right? You've officially made it to the ball game. You're still a little young, still a little stupid, still going to make some mistakes. That's okay. You're better, right? So, and I'm going to quiz you. Is this a STEMI? Yes or no? Getting a little hard. I remember stepping up our game, right? So we've gone over the normal stuff. Yeah, I'm asking questions to the people in front of us and the people online. He said possible STEMI. So this is tricky, right? Raise your hand if you say yes. Raise your hand if you say no. Okay. Yeah. So okay. So looking at this, going back to our whole, oh my gosh, I messed it up. Going back to this, right? Pell's mnemonic. Look at your posterior leads, right? How do you see posterior leads? Do we put an EKG on the posterior side? Nope, right? Suckers. So this is actually just showing us the reciprocal changes of the posterior MI, right? Tricky, huh? Okay. So there's a little way for us to look at it. So if we're concerned about a possible posterior MI, like we can actually see some findings where you have this huge S wave, like this low kind of S wave, and then ST depressions. You can actually take an EKG, flip it upside down and hold it up to the light and look at those leads, and you'll see this. So if you just kind of, does that make sense? Like you flip it up, you're looking through the back of it, and these are what you're looking at for those leads. See how it shows ST elevation? How could you actually get a posterior EKG? Has anyone ever done that before? Yeah, right. So you just add on other leads to just keep going around the same kind of spacing around to the back of the chest there, and it'll show you that. So it's a little tricky, but that's a posterior MI, right? What about this one? Is this a STEMI? Yes or no? Okay, how do we know this is a STEMI? Okay, so ST elevation, contiguous leads, and reciprocal changes, right? Perfect, right? Okay, so this is a STEMI. What kind of STEMI? If you're going to call me and tell me where this STEMI is, where is this STEMI? Inferior STEMI. What are we always worried about with inferior STEMIs? Right-sided MI, exactly, right? So why is that significant if it involves the right ventricle? Sorry? Preload dependent, right? So that ventricle is not contracting, so you're having not enough blood flow. So what do we not give the patient when they have this? Sorry? Nitro, right? So looking at an EKG, how can you tell if there's right-sided involvement? Yeah, right. So what we typically will do is we'll move over so you can see V4 is R. Literally, you just put the lead that's normally on the left side of the chest, you've put it in the exact same location on the right side of the chest, right? So this is the only one that's been switched, and you can see V4 has been switched, right? Let's say you don't have enough time or you don't want to do that. What's a hint that you could show looking at the regular EKG telling you that there's a right side involvement here? It's a little higher level. Sorry? Depression in 2. No, it's a good thought, though. So this is what, an inferior and right-sided MI, okay? No, it's a good thought, though, because that is right-side involvement. But look at our little triangle here, right? Whatever. You can see the heart. Oh, I messed up, right? So 2 is actually pointing more at the right side of the heart, right? And 3 is, left side of the heart. And 3 is pointing more at the right side of the heart, right? So if you have higher elevations in 3 than in 2, you have more involvement of the right side of the heart than the left side of the heart, right? So let's see. Is lead 3 higher than lead 2? Yeah, right? There's a pretty significant change there. So looking at this EKG, it's not perfect, but I highly suspect in this EKG that there's right-sided involvement of the right ventricle, right? So definitely don't give nitro on this patient, right? Really, if you give nitro, is it the end of the world? No, because they're usually very fluid responsive. You just dump a bunch of fluids in them, pressure bag it in, and you'll be fine, right? Still, I'd avoid doing it, and some people actually get hypotension even if it's has nothing to do with the right ventricle when you give nitro. But I personally haven't seen a case where they code or something because you give nitro, but still avoid it. All right, now we're doing like Jedi Master, Obi-Wan Kenobi level stuff here, okay? So we're going to really talk about equivalents and mimics, okay? Those were all examples of actual STEMIs. First thing that's really important to know is you got to listen to the patient, right? Just because somebody, I don't know, stubs a toe, you get an EKG. I know you wouldn't do it for a stub toe, but they just because you see changes on an EKG that make you concerned, if they're totally fine, their story's not consistent with a STEMI, obviously still transport them, still evaluate them, but you got to listen to their story because very, very, very rarely do they not have. Doesn't have to be chest pain, could be dizziness, could be nausea, could be diaphoresis, could be whatever, right? But if they're not complaining of anything other than like diarrhea or I don't know, you know what I mean? But listen to what they're saying. Okay. So what do we see here? Is this a STEMI? Do we see ST elevation? Yep. Okay. So we have ST elevation in contiguous leads. Yep. Do we see, oh my gosh, I already forgot my own criteria. Reciprocal changes? No, right? Good thought, but no, not myocarditis. Sorry? Nope. Good thought, though. We'll get to that too. So this is actually benign early repolarization, right? So this is actually done in a young 25-year-old male, totally fine, right? So how do we know the difference, right? We know it's not a STEMI because they don't meet the criteria, right? But also some things that we can look at, right? So see, what we always say is we look for elevation in the ST segment in the J wave. And the J wave is when essentially you get up to the top of this hill here, for lack of a better term, and then it starts kind of changing, right? So this is actually usually when it's a STEMI, it'd be up like this, but it's actually kind of curved this direction. I know it's kind of minimal, but We call this notching of the T wave, which is totally normal, and especially in a young, healthy person. And it's usually always in these anterior leads. You don't see the reciprocal changes, right? So this is actually normal. This is one of the most common things that we see called in for a STEMI that's not STEMI. But still, if you're concerned, obviously bring them in, right? So this is benign early repolarization. Man, I'm just going to drill you guys. You're going to be like just brain dead by the end of this. What do we see here? Is this a STEMI, first of all? No. What is it? Yeah, exactly. Left bundle branch block. How do we know it's left bundle branch block?
Recognizing STEMI imposters.
Perfect. Yep, exactly. So wide QRS complex. Sorry, what was the other thing you said I couldn't hear? Yep, exactly. So I always ask myself, I mean, this is a little bit harder, but I always ask myself, which side looks funnier? So we got to think this is the anterior. If I'm just trying to decide, QRS is wide, is it a right bundle branch block or left bundle branch block? I always ask myself, which one looks funnier, the right side of the EKG of the precordial leads or the left side of the precordial leads, right? This one obviously left. Now, just because this isn't a STEMI, you still see some changes here, right? So let's go over that, right? Left and oh my gosh. Holy cow, I wasn't even paying attention. This is hard, right? Because it is a little bit wider QRS complex, but it actually is not 3 boxes or more. I wasn't even paying attention to my own thing, sorry. This is a left ventricular hypertrophy, right? Which can give you ST elevation. How do we know if it's left ventricular hypertrophy? So how we know this is, oh my God, I feel like an idiot. So what we do is we look at, see how deep this wave is right here, right? The S wave. See how deep that is? So, oh, you can't see my mouse? Oh, shoot. I've been using my mouse the whole time.
Can you see it now?
No.
Really?
Uh-oh. Sorry, guys.
Just a minute.
Like, oh, just switch to the actual presenter then. That's probably why.
Is that why?
Yeah. Just go back to the normal screen. We'll be fine.
Can you
Okay, there we go. Perfect.
Ah,
Okay.
oh, so much better.
Sorry, guys. Alrighty. Now I can't see all the perfect. How do I get rid of this box? Just get out of the way.
Just gotta put it down
There we go. Okay. Wow. Okay. So see how we have this S wave right here? See how deep that is right there? So to know if it's left ventricular hypertrophy, you add up how deep this is. The deepest this will go in the septal leads or the anterior leads, and how high the R wave goes in the other leads, right? And if you add up the boxes and it's more than 7 big boxes, it's left ventricular hypertrophy. This is obviously way more. So 5, 10, sorry. So 1, 2, 3, 4, 5, 6, 7, 8. We already got it. And then you add up these leads, 8, 9, 10, 11, 12, 13, 14, right? Does that make sense? Exactly. And you can just remember it. The biggest wave in any direction on the right side of the heart added to the biggest wave on the left side of the heart. I'm always about just dumbing it down as simple as possible, right? So that's what makes it left ventricular hypertrophy, right? When you think about like the physics of it, anytime you have a huge electrical signal going in one direction, you're going to have some rebound of it, right? And that's why you have this ST elevation, right? So this is left ventricular hypertrophy, but you can still see there's something going on with this guy. It's not a STEMI, but he has ST depressions down here that he shouldn't be having, right? So that's still concerning EKG, but not because of the left ventricular hypertrophy.
I wish we could actually see the whole thing that he's doing.
All right. So, and you guys see that? Whatever. You can't even see this, but it says still you're still coming into work today, right? Whatever. All righty. What's this one here? Is this a STEMI? Do we see ST elevations? See ST elevations? Are they in contiguous leads? Where do you see them? 2, 3, AVF. Where else? You also can see V4, V5, V6, right? And lead 1, why do you have elevation in 1? That doesn't make sense with those, right? So if you have any, do you see any ST depressions anywhere? Sorry, V2? Maybe, right? So this is our baseline right here. Do you see that? And then so maybe a little bit, but not more than 1 millimeter. So what would this be? So you have ST depression everywhere, but no ST segment ST depressions. Someone said it earlier.
Be nice to be able
This
to
is
see
your
his mouth with
pericarditis,
the-
right? So you have widespread ST elevation, and then you also have, so there's another little thing that we notice on pericarditis. You have PR interval depression. So see, this is your P wave, here's your R wave, right? See how low that is? So you have this PR depression in a lot of these leads, right? So you shouldn't have it dropping down in all these leads, right? So ST elevation, widespread, and PR depression is pericarditis.
Sometimes
I know this is
slowly.
extremely boring, but I'm sorry. All
The
right.
person's having
What about this
thing,
one?
right?
You guys
Yeah.
need a break.
Validation.
You good? Let's keep
We're gonna
powering through it.
treat with our chest
Your
pain.
monsters,
We're
you're
letting them do a place that has a
So-
bathroom. It's not gonna change.
Is this a STEMI?
Doesn't matter. If it looked like a
So we have
STEMI
ST
and our
elevation, inferior
don't care
leads,
about.
Right. kind of spills over the lateral lead a little bit there, right? That's okay. And we have depressions, right? Where's our depressions? Okay, perfect.
I mean,
This
that's
was a
really-
patient that actually had that is not a STEMI, right? But there's no way you're going to know this. Have you guys ever heard of Prinz metal angina? So essentially, this is somebody that's totally fine, but they're having chest pain, sounds like a heart attack. But when they get in, there's no blockage. And what actually happens is you have a lot of spasm of the coronary arteries that makes it look like a STEMI. They end up having no problems, but the only way you're going to diagnose this is in the cath lab, right? So we're still going to treat this as a STEMI. You bring it in the emergency department. There's no way we're going to know it's not a STEMI until they actually take it to the cath lab and see that it's totally normal, and they'll see the spasm of the artery, right? It's more genetic. We actually see it a lot of times with like cocaine users, your monsters. No. A lot of times those are a lot of the patients that you're like, this doesn't make sense. Why is this dude having a STEMI? Like a young, healthy person, a lot of times can still be older, but some people just get it. Yeah. All right, here's a good one. Okay, widespread. I like that. You're very, very right on that. Is there any elevation anywhere? AVR, right? Do we ever really look at AVR? Yeah. This is the one time that AVR is actually important, okay? Anytime you see elevation in AVR and widespread depression everywhere, this is a bad boy, right? So this is actually a proximal occlusion, like either a proximal LAD, or it could be like a triple vessel disease where your LAD, your right coronary artery, and your circumflex artery can all have like ischemia, like huge blockage, right? So this is as even though it's technically doesn't meet STEMI criteria, this is something that's more serious. Yeah, exactly. Yeah. So it's odd that a lot of cardiologists will give me pushback for this sometimes. I think I had like in 2 weeks, I had 2 people that presented with this exact EKG and they're like, oh, well, it's not a STEMI. I'm like, look, you need to take them to the cath lab. And they took them and had huge blockages, both of them. So it's just, again, we don't always look at AVR, but when you have that widespread depression everywhere, it has to be at least, technically at least 6 leads. Then you got to worry about that, right? I don't know. AVR elevation. I don't know. AVR. I don't know. AVR. MI. I don't know. Someone smarter than me would know the answer to that question. So that's, again, like I said, the only time we worry about AVR. I don't know. I thought this was funny. Can you imagine kissing your sister? Hot. No, I'm just kidding. All righty. Okay. Ignore my big blunder with that left ventricular hypertrophy. What do we see here? Left bundle branch block. Perfect. Right. I realized I had made a mistake when I looked at the left side of the EKG and it wasn't really that funny. But see, look, so this is definitely, so B prolonged, right? Prolonged QRS has to be three little boxes or more. This is definitely, I lost my mouse. There it is. This is definitely 3 boxes or more, right? So you can see here, 1, 2, 3, 4 boxes, right? And okay, so there's anytime, like I said, anytime you have that big electrical signal going one direction and it's going to rebound some, right? What about this next EKG? What's this one? Looks like a left bundle branch block, right? But what's different about this? Sorry, who said it? It's a paced rhythm, right? So you see these little pacer spikes right here. There's nothing that would ever cause you to have a straight up and down wave other than a pacer spike, right? And when you put in a pacemaker, you actually cause a left bundle branch block. So the electricity starts on the right side of the ventricle and then spreads to the left side, which essentially causes a left bundle branch block, right? So how the hell are you going to diagnose a STEMI in someone that has a left bundle branch block normally or a pacemaker? Can you do it? How do you do it? Perfect, right? Scarbosa's criteria. Spot on, right? So like I said, just for terminology's sake, anytime, like I said, with electricity, you have this big, huge lead, you're going to expect some depression, right? So you have this big signal and you're going to expect some elevation, right? Some rebounding, right? This is totally normal, okay? And anytime you see a wave going one way and then rebounding the other way, what we call this is discordance or disconcordance, depending on how you ask, but discordant, right? So they're opposite, right? Anytime you see this discordance, it's normal, right? When you have a left bundle branch block or a pacemaker, right? So this is what we call Scarbosa's criteria. Some a-hole decided to name something after himself, so we get confused and have to memorize a name, right? So this right here, so like I said, we expect this rebound, right? So you have this huge wave, you'd expect it to go below the baseline, right? It doesn't go below the baseline. This is called concordance, right? So instead of going down, it's actually elevated. This is a STEMI, right? So this is definitely a STEMI when you have this, right? Because you have ST elevation when it should be depressed. And the same thing over here, right? You should have this big rebound where it goes above, right? You should have some ST elevation, but now there's depression, right? So this is concordance. You should never have concordance, right? And then you have this, which is actually too much, right? So you shouldn't expect it to rebound that much. You have some elevation that actually it's kind of been thrown out. But anytime you have too much elevation, how we decide that is if you have this huge S wave right here, if you have 25% of it, that's usually, it won't go up higher than 25%. Does that make sense? 25% of this S wave, you shouldn't have elevation of more than 25%. Does that make sense? You see what I'm saying? Oops, there we go. But regardless, all I want you to get out of Scarbosa's criteria. This one's not as strong. Cardiologists won't listen to you about this anyways. But anytime you see concordance where you expect to have some depression or you expect to have some elevation and you don't have it, that's a STEMI equivalent, right? That's how you look for an MI in a left bundle branch block or a right bundle branch, or a paced rhythm. What about this one, guys? It's tough. Told you this is gonna get boring, man. What do you see here? Anything? Is this normal? Do you have ST elevation? Yeah, like so these big, huge peak T waves. Almost kind of looks like those acute T waves that we saw earlier, right? But this is actually, it's called De Winter T waves. Another a-hole that named something after himself, so we have to memorize another name, right? So they're called the winter T waves. So let's go back to this. So how you know, so this is very similar. This is like a huge LAD occlusion, right? So this is actually, even though it doesn't meet STEMI criteria, but you have the ST depression with this huge upsloping T wave, big, huge peak T wave. This is actually a sign of badness, de winter T waves. Again, you don't have to memorize all these things, but I want you to at least have heard of these things, okay? It's a good question. So it's what's the difference between this and the DIG scoop, like when you have digoxin toxicity? Honestly, you don't usually get this morphology where you have the ST depression by the huge sloping T waves and the huge peak T waves, usually with the DIG. Yeah, exactly. Exactly. So what about this one? It's a little odd one, huh? You guys are going to be Jedi Masters by the end of this, I promise you. STEMI, not a STEMI. I'll just tell you right now. So this is actually, just give you a little context for the patient. This is somebody that was drunk, found outside in the freezing cold. Has a temperature of, I don't know. Yeah, for this is usually seen in hypothermia. And this is called an Osborne. I don't know why. I added this in because this is supposed to be like Ozzy Osbourne, I thought, and Chewbacca mixed together, whatever. It's stupid. This is called an Osborne wave or a J wave. Okay, so you see how you have this weird kind of bump right after the QRS. Never seen anything look like this before in an EKG. It's not exactly diagnostic, but once you warm this patient up, it'll go back to normal. Some people have a little bump like this normally, but this is what we call an Osborne wave or a J wave. Hypothermia, it'll go away once you warm them up. All right, we only have a couple more things left, and then I'll be done boring you guys. So this is called Brugada syndrome. Okay, have anyone heard of Brugada syndrome before? So this is actually it's not a STEMI or anything like that, but this is a genetic disease about sodium channels that causes this super, super funky ST elevation with this kind of inverted T wave too, right? So this is, when you see this, it's always in V2, V1 that you're going to see these changes. This actually puts someone at a high risk for VFib or VTAC. This is very, very deadly. And usually when you find this on somebody, they're going to get a defibrillator placed, an AICD placed, just because they can go into VFib just sitting there doing nothing, right? So then there's this type 2 of it, which we call, I'm losing my mouse. So we can see this, it kind of looks ST elevation. We call this a saddleback kind of looking thing. You think of it as like a saddle, sit there and have the handle there, whatever. But those are two different types of what it looks like for Brugada, but they both have technically ST elevation, right, in those leads. Obviously no reciprocal changes. That's always what we're looking for. Do we have those criteria that we're meeting? All right, I promise we're almost done. This is another type of Brugada, but we don't need to worry about that. I don't know. Again, just to add stupidness to this lecture. All right. Last thing we're going to talk about. Somebody comes in, like you see them, right? They're having crushing structural chest pain. You show up at their house. They're like, oh, actually, I took some nitro. It's getting better now. You get an EKG, and this is what it looks like. Got this weird, like biphasic is what we call it, T wave, where it starts going up and then down, okay? Called Wellen syndrome, okay? You always have to have that story of the pain is now better when you get the EKG, right? So this is another type of Wellen syndrome where you actually have kind of the same thing, but you have more like inverted T waves that are more pronounced. And here's an even better example, like these huge, deep inverted T waves everywhere, right? So this is another really bad one. This is like another widowmaker, like proximal LAD occlusion, could be triple vessel disease too, right? Badness, right? So this is an example that I had very similar to this, right? So somebody came in, sorry, I messed that up. So someone came in with chest pain, right? So this is the EKG, right? So it has ST elevation, obvious STEMI, right? So they called the pre-hospital STEMI in this patient, right? Gave him nitro, things got better. See, that looks almost normal, right? A little bit off, but it looks pretty normal. Then it's still, the pain's still getting better, right? And then all of a sudden you see this same thing that we talked about, this biphasic T wave in those anterior V2 and V3 leads, and then it turns into more kind of depressions, right? Then the pain starts coming back, then you see the STEMI again, right? So this is bad news, right? This is why we always get repeat EKGs. If someone's chest pain changes, you always should get a repeat EKG to see and look if you're seeing this, right? So if you, just depending on the time on this patient, if you get this right here, right, when their pain's better, you get this EKG and it looks totally normal, right, you're not going to think much of it, right? But if you get it just, that's why this is literally like every 15 minutes they kept getting EKGs. Not that you need to do that all the time, but just depends. You can see this very well. Depending on where their pain is and what stage they're in, you might totally miss a STEMI, right, in this patient, right? So again, these are the things that I want you to take away on what, if anything in the lecture, you've heard of all this other stuff, but these are the takeaways, right? Signs of ischemia, these hyperacute T waves, large peak T waves, right, are always concerning, right? Then we have the T wave inversions, ST depressions, ST elevation, Q wave. Any of those can be signs of ischemia, acute ischemia, which can be important, right? And then what is the definition of a STEMI? ST elevation, right? If you know anything, if you remember anything and you're not sure about EKG, it looks stupid, it looks funny, remember these things and you'll pretty much never go wrong. So what questions you guys have for me now that you're like Yoda level now? I know EKGs aren't the most fun topic, but deal with it. Yeah, any questions on the chat or anything, or?
Let's see. You guys, if you've got some questions, you can unmute yourself and you can ask. We'll listen to you. Or you can put them in the chat. What about, do you guys ever wonder, is there times where, and this happens at all cath labs, that you may transmit an EKG, it may look like a STEMI, and then maybe when you get there, they haven't called STEMI. They haven't, I mean, do you have any questions on, there's a lot of times like on this end of it, they'll look at an EKG and they'll go, and then they'll send that EKG, they'll take a picture of it and they'll send it to the cardiologist. The cardiologist will say, or yeah, call the cath lab, right?
Yeah.
I mean, maybe on that end of it, tell them what you kind of, what you kind of do on that end of it so that you understand what's happening on the hospital and the ER end of it. Because, we always tell you guys, if you guys got a STEMI, call, transmit, we will activate that cath lab. And that, if there's an issue with that, you can always reach out to me and we'll find out what happened. But sometimes there's a reason. And that's what I want you to understand, that if there's a reason, then he can, then we can kind of go through that.
And first of all, I wanted you guys to know, please talk to us. Like, I love talking to you guys. I love doing EMS stuff. I love giving you guys lectures, and I try to make them more interesting than this last one. But ask us. Like, at least the ER doctors I know are happy to talk to you about an EKG. If you have any question about it, please talk to us. I love geeking out on this crap. But a lot of times it's variations of these things too that we see in EKG. We're like, well, it's not a STEMI technically, but it's odd, worried about other things. And a lot of those things are actually these things that we look about. And I would rather you guys always treat, if you have any question about it being a STEMI or not, there's nothing wrong with treating it as a STEMI, right? We will never balk at you. I would rather you treat it as a STEMI and we get things rolling. Sometimes when you transmit an EKG, I want to hear more of the story of the patient. So sometimes I don't call it right away if I'm not sure it's exactly a STEMI. And sometimes I'll just let the cardiologist know, I'm like, hey, I might have a STEMI. But sometimes I just want to see it, get a repeat EKG, see if things have changed at all. So there's always more to that.
It's really good up here at TIMP is that you guys call in or even transmit in when we see that. I mean, especially during the day when everybody's there, like everywhere else when cath labs are there and the crew is there, that there are many times that you go straight to the cath lab. You don't even stop in the ER because they're right there. And that is really, really, really nice up here.
Yeah.
always know that you can always go in, watch if you've got time, you know, whatever you can do, you can always go in and watch that procedure because that's, I don't know, how many of you guys have been in the cath lab and watched that? It's really pretty cool to be able to watch that. And the quicker that you can let us know that it's STEMI, the faster the balloon time's going to be. I can't tell you that more. And here you guys are really, really quick. Those of you that are online, this is really, really important because there are times that you may go into the home, they tell you the story, you do an EKG, and then you may not transmit that EKG until you get into your box and leave because maybe you don't have internet service or whatever the case may be. Sometimes we see delays in EKGs 10 to 20 minutes. That 10 to 20 minutes is a big deal calling the cath lab. If you can transmit that EKG on scene is really, or give us a call and say, hey, you know, we've got STEMI here, because that makes a big difference in filling the cath lab that quick. And in some people, that would make a difference. You know, some people, maybe 10 minutes is not really going to do too much, you know, as far as, but it can, it surely can.
One question I do have is when we're given that call, and you mentioned that you kind of like to hear part of that story, at least for us, when we're going to Tampa or we're going to Valley, a lot of times it's the charge nurse that's taking that. And so therefore, like, I don't know, I guess, like, are they even going to care? Like, it's the charge nurse, like, or do they just want to know, hey, we've got a STEMI and what's on the team?
Well, what I mean is like I just think sometimes if you have an EKG and it's a straight up STEMI, I'm going to call it every time. I don't need any more information. Sometimes what I mean is I don't even know if you necessarily have to give me any information on the call, but what I mean is like I want to talk to the patient because I still might want to activate the cath lab.
If it's not clear.
If it's not a clear STEMI, or if there's something that says honestly, those computers are not always great, right? And I think in the last I think it was a couple weeks ago, I had a EKG that just didn't read as a STEMI. And when I looked at it, I'm like, I don't know how this computer is missing it. This is probably one of the most obvious STEMIs I've seen, right? Computers are not great. They're not perfect, right? They have certain criteria and they try to meet the criteria, but they're just not great. And there's a lot of times that it'll say STEMI when it's obviously not a STEMI. You know what I mean? So what I mean is sometimes I want more information from you guys or from the patient once you get to the hospital. Does that make sense? And if I sometimes taking the call if I'm not busy or whatever, like a lot of times I'll answer when you guys call and I can, yeah. And then I can get some more information from you, but it's usually when you show up. I just mean I might not activate the cath lab unless I have more information, if that makes sense. So.
You get called. Okay, thanks.
Yeah. But I'm hoping to get more involved with you guys. I love teaching. I love doing stuff. I love doing like educational stuff. It doesn't always have to be PowerPoint stuff too. And I can do more interesting topics than EKGs. I know it's kind of tough with those, but yeah. Yeah, good. And hopefully there's stuff in there you haven't seen or heard of before, but you kind of at least, if we say something, like the winter T waves or Brigada or whatever, then you can ask us and sure anyone would talk to you about it.
Are there any questions online? Let's see, there is. Let's see. Which would you call the broken heart syndrome?
That's kind of a longer topic. We can get in that another time. I don't want to bore you guys.
It was an online question.
That's a good question though.
Okay. Any other questions, you guys? Okay.
Oh, really good
Awesome.
information. Thank you.
Yep, you're welcome. Happy to help.
Hey, thanks you guys online. Thanks for joining. I'm just gonna leave this open for a minute if you want to put your name and that on the chat if you need to. I think that was Scott that I just heard. I'll send out certificates so that you guys can have that for your.
And next time I give you guys a lecture, I'll bring pictures of like the broken heart syndrome. We can kind of go over that stuff too. So better than me just trying to explain it. So.
Okay. Thanks you guys. Do you guys
Word.
going to?
Thanks, Chris. You got me down.
Mountain View.
What's that?
Yeah.
You got me down.
I got
I'm
you down,
actually
Scott.
getting credentialed
Thank
at
you.
Temp, and I'm going to work at
Maybe next time you can add a little more
freestanding ER
baby
at
Yoda in
Lehigh
there.
or whatever, Saratoga.
Wait,
But then I'll,
say it again?
I think eventually I'll be like the medical director for some agencies up here too. I don't know about Orem though, but.
Dr. Meyer, did I hear you say you're leaving the South End? What the heck?
I'm gonna just
No, he's not.
staying there. I'm not going anywhere, but I'm gonna work, be a medical director for Dr. Bear. I'm gonna slowly take over some of his agencies, including up here, I believe. So
Okay.
I'm not going anywhere.
All right. Just want to make
Down
sure.
south, you're stuck with me.
All right. We'll take you. See you later.
See ya. Thanks.
Like the recordings, right?